welcome to episode number 3 of Ask Me Anything. As again, this is a format that lots of you have asked for in terms of asking questions for me to give feedback on frameworks and principles that I use. Just a little housekeeping before we start. The same rules apply as before. What I'm going to talk about in terms of answering your questions will be about thinking about how I think about these problems in a broader general sense. In no way can I give specific answers to specific problems that people present here. So as always, any individual medical questions should be taken up with your doctor. So what we're going to do here in terms of answering questions is I will just go through some of the questions that people have asked. I will answer them as best I can. I'm doing this on the fly, so forgive any mistakes, etc. But I'll do what I can to answer all of your questions. The first question is related to Lp(a) or lipoprotein A. And the question is being on statin therapy going to increase Lp(a) levels, and is this something that I've heard of? The literature is pretty clear on this, is that for a percentage of patients, statin therapy is responsible for increasing Lp(a) levels. And just to give context, Lp(a) is a genetic cholesterol particle disorder that's present in about 10 to 20% of the population. So it's super common. And when I hear an early family history of heart disease, it's one of the first things that I'm thinking about. And we know that only about 1% of the population actually get tested for Lp(a). So it's really important that we do that because there are future therapies coming down the line for it. Statin therapy can increase Lp(a) levels, but we do not know as to whether this has any meaningful clinical impact. But what is really important is that between the time that we actually have a specific therapy for Lp(a) and now is that we aggressively manage all traditional risk factors, and higher cholesterol is likely going to be one of those risk factors that we need to target. So the phrase that I use to illustrate this point is just because we can't selectively lower Lp(a) doesn't mean that we can't reduce risk overall. And so I don't see this as an issue, but if we see research telling us otherwise, we will of course change course. The second is again related to Lp(a). And it's to do really around the reference ranges and the fact that it is tested in 2 different units. Someone is saying that the Lp(a) level is less than 75, but someone has a level of 340. So it's really important that you understand that there's nanomoles and milligrams per deciliter or grams per deciliter. Typically less than 75 is considered normal, but in grams per deciliter or milligrams per deciliter, you're talking around 50 or 0.5. Does a higher level confer a higher risk? The answer is based on the literature that we have, yes, there is a monotonic relationship insofar as the higher the levels, the higher the risk. But the interesting thing I would take away from this is that probably more than risk, in my experience, the thing that drives most of my concern or the likelihood of an adverse event or significant coronary disease is the actual family history. So I've lots of patients with an elevated Lp(a) who don't have any coronary disease and have no family history of heart disease. And then I have patients with only, say, moderately elevated or mildly elevated levels of Lp(a), and they have significant coronary disease, and it's generally in the context of a family history of coronary disease. So I put a lot of weight onto that. Now, let's see. Person in their 60s, diagnosis of atherosclerosis and valve stenosis. This person has had a bypass and aortic valve replacement. Medication is Repatha, which is a PCSK9 inhibitor, and ezetimibe, along with aspirin. Blood pressure and HDL typically run normal. LDL is 1.8. Health is good, as you mentioned. Should they have an LDL of less than 1.4? So I would say yes, and how would we achieve that? So 2 things, actually. When I see someone with a history of a bypass and an aortic replacement secondary to aortic stenosis, the most likely cause here is actually Lp(a), which is what we talked about in the first question. Elevated Lp(a) is associated most strongly with coronary disease, but it also has a very strong relationship with aortic stenosis. So when I hear a family history of bypass and an aortic valve replacement, again, it's one of the first things that I'm thinking about. The person's LDL cholesterol here is 1.8, so not a target of less than 1.4, but they're not actually on statin therapy. They're on Repatha, which is a PCSK9 inhibitor, and ezetimibe, which is a non-statin cholesterol-lowering medication, but they're not on a statin therapy and they're not on bempedoic acid. So you have 2 options there to actually hit a lower target. Next question. Is a CT angiogram always indicated if the CT calcium score is above 0? So a bit of context here. When we talk about a cardiac CT, there are 2 tests involved typically. One is a calcium score, so that's just looking for is there calcium, and that's a proxy marker for plaque. How much, and what does that mean for your risk of a heart attack over the next 10 years? A CT coronary angiogram is a much more detailed anatomical test that looks inside the coronary arteries. It looks for any degree of obstruction. It says where the plaque is and if it is causing any obstruction. Now, some centers will have a process whereby they will start with a calcium score, and if it doesn't meet certain criteria, they won't proceed to the CT coronary angiogram. In general, this has been replaced by just doing both at the same time. So most people get a calcium score and a CT coronary angiogram. So I don't think that those algorithms are necessary. How often should a 70-year-old with a calcium score of 400 to 800 repeat a treadmill echo stress test? So a treadmill echo stress test is like a stress test, but you're also doing an ultrasound of the heart at the same time. The question that we have to, I suppose, ask here is that you have someone with stable coronary disease, and are you going to repeat a stress test to find a piece of information that says it may have converted to obstructive coronary disease. Now, in the absence of symptoms, you're in a difficult clinical dilemma, because we know that stenting of stable coronary disease, even if it's obstructive, doesn't really have great evidence to support either making you live longer or prevent heart attacks. Now, that may come as a surprise to a lot of people, and that is pretty recent information, and that is slowly moving through the cardiology community. So the question is if you're going to look at repeating the stress test, what are you going to do with that information in the absence of you having any symptoms? So in general, what I would say is there's no indication for doing a repeat stress test, and we are generally guided by the presence of symptoms. Is there any further updates on the treatment for an elevated Lp(a)? The answer is yes. So the current position we are in is that there are no available selective therapies to lower Lp(a). But antisense oligonucleotide therapies are in phase 3 trials that have been shown to reduce levels by about 80%. Now, we had expected that trial to actually report last year, but it hasn't because of a lower event rate. That doesn't mean that the trial is not successful. It just means that there haven't been enough events yet for the trial to be unblinded. Now, that is expected to happen this year, so that is the, I suppose, update there. But in terms of a trial result, the answer is no. The second thing is, in the last year or so, there have been kind of a significant increase in the number of therapies that are currently being tested here. So the available treatments is growing, and including therapies that reduce levels by up to 100%, and also oral therapies that can reduce levels by about 65%. But the big question here is whether it reduces events, and unfortunately, we are still waiting on that answer. What is a safe daily dose of vitamin D3 and K2 if you have a calcium score above 0? So I have very clear answers on these. The dosing of K2 is very important insofar as I never prescribe it. I don't think the evidence is anywhere near strong enough to support its use. There is some observational and mechanistic data that is promising, but there's no randomized or really strong data to support its use. So in terms of dosing, I don't prescribe it. I don't think it's necessary. In terms of vitamin D3, the answer is very clear. The level, the amount that gets you to your target level. And so the thing that I would raise with you here is that just blindly supplementing large amounts of vitamin D is not actually a good idea. You need to first assess your levels, intervene at a reasonable amount, and then recheck and follow going forward. So just don't blindly take large amounts of vitamin D. I have a high Lp(a) and a calcium score of 500 on statin therapy that lowers LDL and ApoB. Do you recommend the addition of low-dose aspirin because of Lp(a) being prothrombotic? So this is actually raises a very important question. There is evidence, although it is not randomized evidence, to support the use of aspirin therapy to reduce cardiovascular events in those at high risk with an elevated Lp(a). So again, it's not randomized, it is an observational data set that we're looking at. So we tend to consider it more in those who are at high cardiovascular risk, especially if they have an elevated Lp(a). The problem is the use of aspirin in general in primary prevention, and we're using less and less and less and less aspirin. In general, I reserve it only for very high-risk patients in primary prevention, so they will have to have a significantly elevated calcium score. So this person has a calcium score of 500, and that is a very high score. A score above 300 puts you at the same risk of having a heart attack as someone who's had one before, which is very high. So I think it can be considered. It isn't mandatory, and certainly if anyone has any bleeding risks or side effects like bruising or bleeding, I would be very quick to stop it. 55-year-old male on statin and blood pressure lowering, already performing training, aerobic and resistance, would like to increase protein intake to 1.6 grams. What about the effect on kidneys on protein intake, especially in the case of cystatin C value of 1.3? What would it be better to aim for less than 1.6? So the question really I'll answer broadly here is the issue around taking protein intake levels to slightly higher than the recommended of 0.8 grams per kilogram. So this person is saying up to 1.6. We know that a reasonable amount is about kind of 1.2 grams per kilogram for most people, and incremental amounts thereafter will have diminishing returns. But the question is in the setting of mild kidney disease. Now, all the guidelines that you look at in terms of the Kidney Association guidelines will say that higher levels of protein intake are not advised and may worsen kidney function in the setting of chronic kidney disease. That is based on observational data primarily. It is based on mechanistic and biological data. But when you actually look at the randomized control data, the evidence for that really isn't there. So I'm not sure how those guidelines actually make that recommendation. I think you're always going to track kidney function and see if an input change causes an output change in the kidney function. But I don't get too worried with modest increases to appropriate protein intake levels in mild CKD when someone is doing resistance training to build and maintain muscle mass. Someone has a research question. They're about to do a fellowship. Do I have any suggestions? What I would say is they've mentioned a couple of different topics. The important thing is if you're going to do a research topic, you have to enjoy it. So if you're someone out there in fellowship opportunity doing research, do something that's enjoyable in terms of answering the question. But what I would say even more than that probably is go somewhere that you will learn how to do the actual approach. So the topic then becomes less important, and the people that you work with and how you go about doing that work and even where it is very important. When I was doing my research fellowship, I worked with Dr. Eric Topol. You may know him from Twitter, but he was also based in San Diego in California, and I could think of nothing better than spending some time in San Diego. So choose those factors as a way to think about that question. 45-year-old male, TRT for the last 3 years, went for a calcium score, which resulted in a 0 calcium present. I know I'm not scot-free. Is there anything else you would recommend keeping an eye on? The answer is yes. I think about keeping an eye on everything. So you have to think about this in terms of having a calcium score of 0 at 45 years of age. In general, males get to about 54 years of age before half of all males will have a calcium score of 0 and half will have a calcium score above 0. That happens at about kind of 66, 67 years of age for females. So having a calcium score of 0 at age 45 years of age is the very likely outcome for the absolute majority of people. And so that really means very little beyond the fact that you actually don't have early significant premature coronary disease. And what you need to look out for is everything, all of the traditional risk factors that we generally talk about, rather than just looking at your calcium score. High calcium score of 316 with some calcification of the coronary arteries, was prescribed 20 milligrams of statins, dropped my cholesterol levels very low, having even dropped back to 10 milligrams, I'm getting significant muscle pain and stiffness. I've now stopped the statin medication. Is there an alternative? While I can understand the merit of reducing high cholesterol levels, is there risk causing other metabolic issues as it is a required protein? So it is a required protein, but pretty much every cell in your body makes enough cholesterol, so I don't worry about taking it too low. You've talked about saying cholesterol levels very low. The answer is for someone with documented coronary disease, which this person has at a calcium score of 316, which we said has an equivalent risk of a future event like a heart attack as someone who's had it before, so high risk, there really isn't a too low level. And we have very good evidence to support its use over longer periods without any future, certainly cognitive effects or metabolic effects. There is a small increased risk of diabetes in those who have pre-diabetes, but in general, that's something you're going to be tracking over time. But the important thing here is that this person has muscle aches and joint pain or stiffness. There's no really need to be on statin therapy. There are alternatives: ezetimibe, bempedoic acid, PCSK9 inhibitors, and inclisiran. There's ways to get to target without even using a statin therapy, and even a lot of people can be retrialed on a different statin therapy. So loads of different options to work with. Are high blood pressure sleep apnea notifications sufficiently reliable to warrant upgrading to the latest Apple Watch? I have an Apple Watch. I can't give you an answer there. I'm a heavy snorer and wondering if it would help eliminate my concerns in this area. The answer here is don't rely on your watch, regardless of the actual, whether it's new or not from Apple. Get on a sleep study with a sleep physician. So don't get your watch. Don't try to do this at home. Do this with your doctor. A sleep study is what you need. I declined to take statin therapies 10 years ago. My GP suggested starting, was concerned by my friend's anecdotes. So you listen to your friends and not your doctor, not a very good strategy. I'm 79, can walk 3 miles. Is it too late to begin statin therapy? So what I would say is the question here is there a time at which it is too late to start statin therapy? The answer actually is no. If you have someone in good health, what this person absolutely sounds to be, there is evidence we have in randomized data to suggest that even at this age category, there is benefit. Clearly, the benefit will be greater, started earlier, but what I would say is that there is still benefit to actually risk reduction based on overall risk. Hi, husband has a calcium score of 150, is on a blood pressure medication with a recent 10-day average of 148. His cholesterol is an LDL of 2.7. Can lifestyle changes reduce this cholesterol, or should he go on a medication? So just to put this in context, you have someone who's got a calcium score of 150, which is an elevated calcium score. So the answer is you need to get to target of an LDL of less than 1.4. I would argue you do that with a medication. That's the most effective way to do that. Can lifestyle changes reduce cholesterol, LDL cholesterol specifically? Yeah, but it's just not great in my experience. And even if it does work temporarily for someone, the sustainability of that is not great. The second thing is, having documented coronary artery disease and a blood pressure average of 148 is way above target. Everyone really should be hitting target systolic blood pressures in the low 120s or below, with very, very few exceptions. Hi, moderate osteoporosis. Do I need vitamin K2 to direct vitamin D to bones and not arteries? I do not know where this is coming from, and I know the mechanistic data around calcification in coronary arteries, but the evidence to support this is not there. You do not need vitamin K2. Just no need, no need, no need. You can take vitamin D, and also in terms of calcichew, it is totally reasonable to take calcium chew even if you actually have documented coronary artery disease. There is observational data to suggest worse outcomes in those who take calcichew as opposed to those who don't, but that is likely, very much so, to be confounded by an unhealthy user bias or a healthy user bias, whichever way you want to describe it. Although it makes sense, if I eat calcium, it's going straight to my arteries. It doesn't work like that. It just doesn't work like that. So no K2, no problems with calcichew. Could you angiotensin receptors, go into detail of the mechanism by which angiotensin receptors and cause bradykinin and cough and angioedema. Very complex kind of question here. The bottom line is what they're asking really is that some blood pressure medications, specifically ACE inhibitors, so anything that ends with a pril, so if you're on ramipril, perindopril, etc., can cause a dry cough in patients. It's very common, and it's related to bradykinin levels, as is mentioned here. It's not dangerous, but it can be very bothersome and is easily fixed by switching to something else. Would you consider adding hydralazine for control of blood pressure in a 70-year-old patient with side effect from ACE inhibitors, ARB, amlodipine, cannot tolerate them? Yeah, sure, we can use hydralazine, but there are other medications that can be added in addition to the ones listed. There are 4 core, I suppose, categories of blood pressure medications that we use, but even within each category, there are subcomponents of those that may have better tolerability than others. But beyond that category of 4 core approaches that we often start with, there are many, many others that do not include hydralazine. So yes, I would consider it, but it's not going to be near the top of my list, and there's lots of others in between. Is there anything to do with limiting blood pressure during exercise being too low? I think your blood pressure will rise temporarily during exercise and fall shortly thereafter. Clearly, if it's impacting your ability to perform, I think that's always an issue. Furosemide is listed here as one of the blood pressure medications. I typically don't use furosemide, which is a loop diuretic for control of blood pressure. It is very commonly used for the management of heart failure. But in general, if someone is hitting their targets in a rested state, is performing fine, I tend not to get too obsessed about looking at exercise blood pressure changes. What supplements do you recommend? Practically none. I take creatine most of the time. I take vitamin D during the winter because my levels tend to go low, but it is purely driven by checking my levels, they going low, and then me supplementing it with enough vitamin D. And, you know, there's probably some evidence to support omega-3 fish oils. It's a low-risk intervention with potentially some benefit. But beyond that, don't recommend any other supplements. People often come into me with lists and lists of supplements, and I just don't think they're necessary. Can anything be done to remove plaque on a non-invasive basis? So the answer of remove plaque, the answer is no. If I remember correctly, many years ago, many decades ago, there were studies on an invasive basis to go in and use kind of like a cheese cutter approach to actually pull the plaque out, and it made things way worse. On a non-invasive basis, we can't remove plaque. We can regress it to an extent, and the evidence that is most linked to that being a successful approach is very aggressive lipid-lowering therapy with LDL cholesterols of less than 1.4. What time frame is recommended for repeat CAC scoring when first CAC scan was 0 for the patient? What I would say is this is a question that has no specific answer, and when you look at the guidelines, you always have to ask, is the repeat scan going to change your approach? I think for a high-risk patient, you're talking about 3 years. For a lower-risk patient, maybe 5 years. There's no specific answer, is the honest answer here. I hear you mention about getting to target a lot. I'm 50 and on 10 milligrams of statins. My most recent test gave me a total cholesterol of 4.7. Weight and blood pressure are fine. I do have a family history of cholesterol and heart disease. What would you consider as a good target for someone like me? So in general, I wouldn't go off total cholesterol. That's a metric we really don't use at all. And so we're going to be using non-HDL or LDL cholesterol or ApoB. What I would say is the simple one is just getting your LDL cholesterol to less than 1.8. If you do not have documented coronary disease, if you did have documented coronary disease, we might push things even harder down to less than 1.4. How you get there really doesn't matter. The real thing that matters is that you get there. Blood pressure control has been a challenge. Morning blood pressure is 98, rising to 136 in the late afternoon. I'm currently on 10 milligrams of olmesartan. I have a pacemaker. Is there a better medication choice? Perindopril, for example. So someone here has mentioned splitting the dose 5 and 5, and that's olmesartan. So 10 milligrams of olmesartan is actually the lowest dose, so it's hard to split that. What I would say, I think the suggestion though of kind of looking at a medication you can split to AM and PM is a reasonable suggestion. It may require a smaller dose of a different medication, but this is a trial and error thing to actually look at that over time, and there's no super evidence to suggest that one is better than the other in terms of taking nighttime medications versus daytime, but I think splitting them in consultation with your doctor is a reasonable thing to do. What are your thoughts on people taking oral minoxidil and topical for hair loss on its effects on the heart? Be interested in it to know, as it has a black box warning. So minoxidil is a therapy which I always am reminded of Homer Simpson when he bought minoxidil in the black market to actually grow his hair. But it is used for hair loss at very, very, very low doses in comparison to what it is used typically in cardiology for the treatment of high blood pressure. And its high blood pressure is one of the last on the list that we're ever going to use, as there are significant potential side effects. If I remember correctly, things like pericardial effusions that can be caused. So it's something that we rarely use in cardiology, but when we do use it at doses that are way higher. So I'm not particularly bothered for the doses used for hair loss. And we just have to be mindful that there is potentially a small blood pressure lowering impact from it. Again, do you need vitamin K2 with vitamin D directed to your calcium and bones? No. Yeah, this is just a big one on social media. No, you don't need vitamin K2. I have a strong family history of heart disease. ApoB is 30, Lp(a) is 77. Is there a strong likelihood I have blockages? I am 37. I've had a poor diet growing up but never overweight until now, postmenopausal. So the key thing here is that family history is not destiny. There are three things that I always think about. Number one, you may have a genetic risk for heart disease based on it being in the family, but you may not have inherited that risk. And even if you have inherited the gene, it doesn't necessarily mean that you will express the disease the same way as a family member. Now, the likelihood of having heart disease as a 37-year-old is just exceptionally low. So yes, you may have risk factors, but the probability of having blocked coronary arteries at age 37 years of age, although it is not zero, is very low. Because as we said, for males, they start to develop more advanced plaque on CT imaging in their mid-50s, females in their late 60s. I'm 33, healthy, VO2 max 53, body fat 12%, good musculature, Mediterranean diet, my cholesterol and ApoB is slightly elevated. Should I go on a statin or focus on lifestyle/diet? So the answer here is there's no particular level that you need to go on a medication or not. There's only your degree of risk over your lifetime. So what you need to do here is you need to estimate your lifetime cardiovascular risk. There's lots of calculators that you can do that. And when you actually put into the calculator the difference between on and not on lipid-lowering therapy, you can get a very good estimate as to what the lifetime benefit for you could potentially be, understanding that it's always a bet. I think in terms of if your levels are slightly elevated, you really have to ask slightly elevated above kind of what threshold. And lifestyle and diet, again, I really think that these approaches are not the best approaches to LDL cholesterol. For blood pressure, sure, lifestyle in terms of reducing blood pressure can be a really powerful tool. But for LDL cholesterol, you're talking about pulling two big levers of reducing saturated fat and increasing soluble fiber, giving you about a 15% reduction in LDL cholesterol. And for this person, that might work, but for someone with significantly elevated LDL cholesterol, it is unlikely to work. 43, female, big family history of heart disease, people in their 30s, having lots of symptoms but no blockage found, except for severe vessel tortuosity and very high Lp(a). On aspirin and statins now, still have symptoms. Is there anything else I should be doing? So high Lp(a) levels, you can get what's called microvascular disease. And so this is something that we have learned an awful lot more about, where you can have someone presenting with classic chest pain, angina symptoms, but have non-obstructed major or macro vessels. They were often told that it was all in their head. What we found is that you can have what's called microvascular disease, and that can give you the exact same symptoms. The problem is that there's no stenting options for that, and it is predominantly a medications option. There are specific tests, both non-invasive using cardiac MRI and newer invasive tests that specifically address this question, but the invasive tests are done really only by a handful of centers. So you really have to get linked into the cardiology community to get that specific question answered. Does having preeclampsia while pregnant always mean a recurrence as you age? The answer is no. It increases the likelihood for sure, and we've gotten much more aggressive about how we manage blood pressure during pregnancy. It does increase the likelihood later in life, but it doesn't guarantee it. So just again, you're always monitoring your blood pressure and seeing where things are. A 52-year-old female, what is the evidence for intermittent fasting and prevention of heart disease? Over the past 3 years, I've been adhering to an 8-hour window since hearing a cardiologist discuss. So intermittent fasting, there's no magic in fasting as far as I'm concerned. It is a fantastic tool for reducing caloric intake. It's also really simple to understand. It costs nothing. There is no prep and there is no cleanup. So it is a tool that I have personally used in the past, and I know lots of my patients use. But fundamentally, if you just said, I'm going to cut out lunch or breakfast, that's intermittent fasting for most people, and you've just dropped a caloric load of that particular meal. But it's the calorie reduction, or if the calorie reduction kind of purely that drives the benefit of intermittent fasting. People will talk about increasing autophagy, and if anyone says that to you, they're simply hand-waving. There is no reliable test for measuring autophagy in a clinical setting. So no, I think intermittent fasting, fantastic tool to use, and I've used it myself. It's really simple to explain and understand and actually implement, but there's no magic in the fasting with that. Question, for a person who has had 2 stents over the last 10 years, what's the latest technology that is non-invasive, i.e. not an angiogram, that can detect the need for another stent best? Apparently CT angio are not reliable when there are already stents, plus it's old tech. So a couple of things. CT angiography is not old technology. Yes, it was invented a long time ago, but the actual software algorithms and the hardware that is actually being used now is absolutely phenomenal when you look at photon counting, for example, and even the ability to detect in-stent restenosis with the much, much newer platforms, which are not broadly available. Secondly, the question really is the person is saying they've obviously had stents, they're looking for the restenosis or a narrowing of those stents, but this goes back to a question that we asked at the very start. What are you going to do if you determine that one of those stents has narrowed and you have no symptoms? The answer is you're going to stay on medications for the most part, unless you develop symptoms. So you always have to ask yourself, what have I opened up in terms of a Pandora's box when I ask these questions? So the most reliable technology, non-invasive, would probably be what's called a perfusion cardiac MRI, but you're going to have to ask yourself what you're going to do with that information. Do weight loss injections actually reduce coronary artery disease itself? I.e., we know weight loss is healthy for the heart, but wonder, does the pharmaceutical way actively reduce risk? This is a very interesting question. We know that in people with documented coronary disease at high cardiovascular risk, weight loss medications like semaglutide or tirzepatide, Ozempic and Mounjaro, reduce cardiovascular events by about 20%. Now, the trials were looked at in retrospect, so this was not part of the original power for the trial, and they found the same reduction in cardiovascular events in those who lost less than 5% of their body weight versus more than 5% of their body weight. Now, it doesn't reduce the coronary disease that we have evidence for at this time, but it certainly reduces risk. So it definitely reduces risk and is an option that I'm using more and more for my patients with coronary disease. Good morning. Are there medical reasons for avoiding the use of infrared sauna if you have a single well-established stent? Not that I'm aware of. So I think it is entirely reasonable to do. But of course, if you go in a sauna and you get chest pain symptoms, that should prompt you to think about something else. So there's been one or two other questions, but we've been going for about 30 minutes now. I'll just look at one here. I have a calcium score of 3,900 but at 52, but pass a stress echo at 13 minutes with great capacity, according to my cardiologist. So how is this possible? The answer is you can have multivessel coronary disease and completely have a normal stress test or stress echo, because it tells you you have plaque, albeit extensive, but unlikely to be obstructive. I have patients with calcium scores over 6,000 who have normal coronary arteries, in terms of, not normal, they have non-obstructed coronary arteries. So just because you have calcium score in the thousands doesn't mean that you have obstructive coronary disease. It increases the probability, but doesn't guarantee it. Okay, so number one, thank you for everyone who submitted questions. I'm always surprised at the range and breadth in terms of what people are interested to know about. This is something that we'll probably do on a frequent basis, but we can only really do it, A, if people submit their questions, and B, if people enjoy it and think it's a good idea. So if you think it's a good idea, put a comment in the comments section below and just say you thought this was good or not, don't want to see more or a different format. And if there are different formats that you would like to see, just let me know and put it in the comment section below. Okay, thanks so much. And as I always say, keep the odds on your side.